Master of Science degree for lasers and dentistry from Aachen University in Germany in 2005. He is adjunct faculty and representative of Aachen Dental Laser Center in Aachen University in Germany and in the United Kingdom. Dr. Madden is a lecturer for ACT, of course, the Laser and Health Academy, and a training instructor for the International Continuing Education Center for Dental Implants. Dr. Madden is currently authoring the Lasers and Periodontics chapter for the updated version of the Evidence-Based Dentistry on Laser Dentistry. Also a member of the editorial board for Lasers and Medical Science. His work has been published internationally in a Journal of Periodontology, International Journal of Medical Sciences, the International Magazine of Laser Dentistry, and the Journal of Laser and Health Academy. He's a principal dentist in a private practice. He's been performing laser-supported implantology and periodontal treatments since 2005 in both Istanbul and in the UK as well. We are more than honored to have him with us this evening to discuss how he uses the Lightwalker dual wavelength laser for the treatment of Peri Implantitis. Without further ado, Dr. Madden.
Thank you very much for your kind words, Dimas, and good afternoon, good evening, and to some of my colleagues here around Europe, good morning. So I will be talking about, as mentioned, about Peri Implantitis treatment. As we always say, this is really a fuse bomb, and we know that there are few ways to stop the fuse to go. We really feel like the laser is the best tool to do so. So, well, we will start with the risk factors for Peri Implantitis, because we should really be aware of these risk factors, and we know that they really play an important role in the treatment part too. The cause of Peri Implantitis, of course, will be our next subject, and then the signs of Peri Implantitis, followed by the treatments. Of course, we'll do a little literature review on what the lasers were used for the Peri Implantitis treatment, how they interact with implant surfaces, etc. And we will finish up with some cases. Well, of course, we have two groups of risk factors, one being the local factors, and of course these leads to microbial colonization. The general factors would be increased susceptibility of the hosts. The local risk factors, the first one would be the oral hygiene of the patients. This is also related to the position of the implants and the restoration design. Not only the patient being able to clean the surfaces of the restorations, but if the restorations were made easy to be cleaned. Of course, it's more rare, but possible to have some foreign body reactions by the patients. Periodontal health is one of the most important risk factors. Soft tissue conditions, especially attached gingiva, high frenulum attachment, etc. If we do not have enough attached gingiva, it's very difficult for the patient to clean. And if the patient is not able to clean, again, we come back to the first local risk factors, and then we have the accumulation of the plaque, and then, of course, the infection of the site. Initial peri-implant pocket depth, this is also an important factor. Usually, many of us may try to just leave the thick gingiva above the implant when we uncover the implant, but if it is more than 3 millimeters, it would be the best idea to make a little bit connective tissue removal so that we have less tissue thickness, so that we don't have a really deep pocket around the implant from the start. The roughness of transmucosal parts is also an important subject. Of course, we know that some companies try to say they offer a little bit rough transmucosal surfaces, saying that there will be more attachment of the fibroblasts, so it will be less risky for peri-implantitis. The problem is, as long as we have the attachment, of course it's good, but the moment you start to have an infection, of course the rough surfaces are more difficult to clean by the patients, so the infection would be easy. It will be easy for the infection to go deeper and deeper. Implant prosthesis connection, of course this is also very important because we should have gapless connection. If we have micro movements or micro gaps, that will also cause some microorganisms to accumulate in that connection space, and then that will go on with a peri-implantitis. These are important because if we do not consider all these steps, even if we have a very successful treatment of the peri-implantitis, it will recur. So we should be able to foresee these problems, the possibility of the infection, and then try to solve them before it happens. Of course, we have the general risk factors, history of or remaining periodontitis, and today we know full mouth extractions, even that, do not eliminate the periopathogens. We see some studies showing the samples showing the periopathogens just after the extraction, and then the researchers have waited 3 months for the full healing of the socket, and then uncovering the alveolar. Before placing the implant, they get a sample from the bone with a trephine burr, and then we see that pathogens are still there inside the bone after 3 months. So this is a very, very important sign to show that not only cleaning of the socket is enough, but we have to have some tools to disinfect actually the inside of the bone. Genetics, of course, that influences the inflammatory response, especially aggressive periodontitis patients, is a high risk factor for peri-implantitis occurrence. Acquired factors like diabetes, very important, and today, of course, we know that the blood sugar level is not enough, but we should be checking the hemoglobin A1C for the control of the diabetes for the last 3 months. Environmental factors, smoking is a real big problem in this part of the world. It's very rare to find a patient who does not smoke or even smokes less than 10 cigarettes per day, so that really limits us for both the treatment with the implants or later on if we have infection around the implants. And then again, stress and alcohol consumption are important risk factors. The cause of peri-implantitis, of course, we can say we have 2 main causes, one being poorly decontaminated site following the pre-implant extraction of teeth. Whether the tooth will be extracted because of periodontal or endodontical infections, of course, the site should be cleaned thoroughly before placing the implant. If this is not possible, the implant placement should be done later on, and as I already mentioned, even that may not be enough. So we have to clean the contaminated site. Then, of course, we have the microbial colonization after the implantation. That would be because of the reasons I have already explained. What the signs of peri-implantitis are, of course, bleeding on probing. It's very important to actually wait minimum 30 seconds after we probe to check if there is any bleeding. So a few seconds may not be enough, but we have to wait until we see the bleeding. That could take up to 30 seconds. And of course, with the smokers, we have less vascularization in the oral mucosa, So that would mean even if there is an infection, it may not be easy to see, and the gingiva could look like really healthy, whitish, very light pinkish color, but still we could have some infection inside. So we should be checking the probing depth. As I already have mentioned, we should be noting the initial probing depth. So if it was deep from the beginning, it could be the case that it does not get infected, but it's still just deep without any active infection. But if there is an increase in the probing depth, of course that shows a loss of tissue. Pus is of course an obvious sign of infection. Then loss of bone visualized radiologically. So if we see all of these, it's time to do something. So treatments. Of course, first goal is to control the infection and to do the detoxification of the area. Lasers are very effective in achieving this goal. We know the disinfection properties of the lasers from periodontal treatments and odontical treatments, and even from some oral diseases, including the viral lesions. So we know that we can get rid of bacteria by the use of laser energy. A developed peri implantitis lesion cannot successfully be treated with non-surgical therapy alone. This information we know now through lots of studies. So if there is a loss of bone more than 2 millimeters, pocketing more than 5 millimeters, we now know that we have to access the site to clean all the granulation tissue and detoxify the surface of the implant, and also the bone, of course. Care should be taken not to harm the surface of the implant while doing so, and we know that we have a few options to clean the site, but none of them are safe in regards to really not changing the surface of the implant, whether we use carbon curettes or titanium curettes or brushes. There is a risk of scratching the surface of the implant and removing the original ossified surface. Of course, antibiotics should be prescribed very carefully because we know antibiotic resistance is a growing problem around the world. Even for the regular antibiotics that we use, we see some resistance now because of peri implantitis and periodontitis, even endodontically prescribed antibiotics. So if we can solve the problem without using in antibiotics, we should do so. So treatment, of course, goes through a flap that can be raised to achieve a direct access to the defect, to remove the granulation tissue, and decontaminate the threads effectively. It's not possible to reach the accumulation, whether it's the plaque or the granulation tissue around the implant, in between the threads, if we are not able to raise the flap. So that's one of the main reasons why non-surgical treatment usually fails, whether we use the laser or not. Of course, citric acid was used, chlorhexidine, local and systemic antibiotics were used, hydrogen peroxide, air powder abrasives, photodynamic therapy, which is also a kind of laser treatment, but there the laser is just to activate the liquid that's used, so it's not really a laser treatment, and implantoplasty using burrs. All these were tried with limited success over each other, and with some of them it was seen that there could be some negative side effects. And then, of course, nowadays for some years we have been using lasers to decontaminate the threads and also to detoxify the surface of the implants. vaporize very quickly. Of course, vaporization of the water molecules means that they're expanding, and this expansion is just like a micro explosion on the surface. And these explosions create a negative pressure on the surface, so that detaches whatever is on the surface of the object, whether it's the caries on the tooth, whether it's the calculus on the root, whether it's the granulation tissue on the implant. Depending on the strength of the laser that's being used, it can selectively just remove whatever is on the surface without hitting the lower levels. Of course, it's very important to evaluate the defect morphology for regenerative intervention. If it's going to fail, it's going to fail. It's just about the morphology, the physiology, the vascularization of the grafts, the coverage of the grafts or the membrane. So whether we disinfect perfectly with the laser or not, the regenerative treatment is, of course, another step of the treatment, and it should be also evaluated very carefully. Again, evaluation of the surrounding soft tissues for the coverage of the augmented defects. If there is not enough attached gingiva, if there is not enough vestibular depth, these all should be arranged before doing the treatment. So coming to the literature review, what we see that was already published, we see that, for example, in this literature, to avoid surface alterations on the implant, we have to use different energy settings depending on what the surface of the implant is. So titanium plasma surface, the sprayed surface, is the softest. So with 9 joules per centimeter square, they start to get some alterations on the surface. Then we have sandblasted surfaces with 11 joules per centimeter square, and then we have hydroxyapatite coated surfaces. Of course, this amount of energy is needed for the alteration below the hydroxyapatite. So that's actually the surface of the titanium. And then, of course, the smooth surfaces, the machine surfaces, are the hardest, so they require higher energies to get altered. So that means, depending on what the surface is, we have different limitations to be on the safe side. Another study showing the alterations of polished and sandblasted and acid-etched titanium implants with Erbium lasers. And the polished titanium you see with 100 millijoules, that is about 12 joules per centimeter square, shows no change on the surface. And even with 300 millijoules, we see no change. Then if you go up to 500 millijoules, of course, we start to see some alterations, which is, of course, very high energy that would even remove enamel. So we are not using that kind of high energies around the implants. So sandblasted acid-etched implants, 100 millijoules, we see that we are safe with no alterations of the Hertz and an SP pulse duration with non-contact handpiece that is used 4 mm above the surface for 60 seconds is totally a safe setting. This one is interesting, again showing even without cooling it would be possible to use the laser without getting an increase of temperature higher than 10 degrees. Of course, it takes very short time, even with low powers like 100 millijoules, to go above 10 millimeters of increase of temperature. It takes about 5 seconds, but even in 5 seconds, which is a long time, even if there is a problem with the water spray, etc., we see that the Erbium laser is very safe on the implant surface. And with the water spray, we see that on the apical part, it was never reached the 10 degrees increase of temperature. So it's safe. Okay, now we know that we are safe with the implant surface, but is it effectively killing the bacteria? Yes, we see that even with low energies as 60 millijoules, we have a disinfection of 99.5 with sandblasted implants, and 98% with hydroxyapatite covered implants, and 99.6% for titanium plasma sprayed implant surfaces. Going up to 120 millijoules, we see that we are around 99 to 100%. So it is very effectively killing the bacteria without excessive temperature elevations or morphological surface alterations. And they have already seen that critical temperature threshold of 47 degrees was not exceeded even during a continuous 2-minute irradiation period. Another study comparing and evaluating the antimicrobial effects of Erbium and other wavelengths on titanium discs. And here we see that with 10 millimeters distance and on SP or MSP mode, even with 80 to 90 millijoules, we see that we have a very nice disinfection of the surfaces. $80 millijoules and 90 millijoules with 5 Hertz on SP and MSP. We see that we have an elimination of 100% of the bacteria with 90 millijoules with 10 Hertz, even in a short time period like 10 seconds. Again, the contamination for machine tests, machine surfaces up to 76%, and then titanium plasma spray implants up to 90%, and then sandblasted and acid etched implants 98.3% of bacterial removal. This is also very interesting. We see that if we evaluate the attachment of human gingival fibroblasts and their proliferation rate on the laser-treated implant surfaces, we see that we have a similar result in sterile implant surfaces and the contaminated then laser-treated surfaces. So that shows that there is a full detoxification and the fibroblasts proliferate on the implant surface just like as if it was not even touched. So there is no surface alteration, and this is attributed to the removal of cytotoxic bacterial side products, cell components from the titanium surfaces. Again, this is done with 60 millijoules and 10 Hertz, and even without water, the same result was seen. Another evaluation shows that the treatment with an Erbium laser, again with a pulse energy of 60 or 100 millijoules, do not reduce the biocompatibility of the SLA titanium surfaces, and in fact, modifying SLA surfaces with the Erbium laser improved the biocompatibility of the surfaces. So we are not only safe with the non-alteration of the surfaces, but even we have a better surface for biocompatibility. This one is interesting to just show that it is also very possible to clean the gingiva formulas or the abutments. So we know that sometimes calculus accumulate on the gingiva formers, which may be used again for other patients. And before Wavelength laser on degranulation and implant surface debridement, now a clinical study, a histological study, shows that the laser group has a tendency to produce more bone-to-implant contact than the curette group. This information about bone-to-implant contact percentages, in my opinion, very important for two reasons. One of them being regarding the support of the bone for the implant and occlusal forces. So if you have more bone actually physically touching the implant in that sponge's bone, that is of course higher support for the occlusal loads. And then talking about peri implantitis, if you have more bone around the implant, of course, it could be a question of time for the patient to seek some treatment for peri implantitis. So the more bone we have, it means it will take more time to resorb that amount of bone, which is an advantage in case of peri implantitis. Further reading, I can recommend the peri-implant infection etiology, diagnosis and treatment book by Frank Schwartz, which is very experienced in laser therapy. Then Periodontology 2000 article, The Impact of Laser Application on Periodontal and Peri-implant Wound Healing, again by Dr. Schwartz and his friends, which also in this article includes Dr. Aoki, Scullion, and Becker, which are all very experienced periodontists with, again, experience in using lasers. Laser treatment of peri-implantitis, a literature review by Dr. Ashnagar. You can see and have a look at this review to see what was also researched. Coming to the cases, again, you can see a pretty healthy looking gingiva. Of course, now we can see a little bit of blood coming out from the pocket, and of course that would seem that there is a problem over there. And it's not as bad as it doesn't look as bad as it actually is, because this patient is a smoker, but has been smoking less than 5 cigarettes for more than a month. So it was a good candidate for peri-implant treatment. You can see the defect around the implant, especially on the distal and lingual part, and then we have a very complex defect which is going from the lingual part towards the vestibular part, leaving just a little bit of bridge of the bone on the more coronal part, but the defect gets deeper on the apical part. This is the first part of granulation tissue. As soon as we open the flap and get in with the laser, and the laser detaches the granulation tissue very easily from the bone and the connective tissue of the flap. So this is the first bulky piece that we get out. And then we go on cleaning with the laser, which we will be able to see on the next cases, even with videos. We can achieve a very nice cleaned defect with decontamination of the implant. If the position of the implant is close to ideal, which in this case is, then it's very possible to, of course, augment this site. Here we can see the implant is actually just in the middle of the alveolar, and the defect is circumferential with very little loss of bone vertically. So if we are able to clean all the granulation tissue, if we are able to clean the space in between the threads of the implants, then it's a good candidate for augmentation. And then of course we place the membrane and then the grafts. Here you may be able to see the reason of the infection actually. I don't know if you do. I'll show you later on in the next slides. Then we cover the grafts with the membrane and suture up. Here you can see the reason. Actually the screw was broken, so the micro movement of the crown and then the plaque accumulation resulted in the circumferential defect around the implant. And this was after 6 weeks. We could start to see the implant, but it's no problem. You'll see on the X-ray after 6 weeks, still we have all the grafts around the implant, which shows very nice results. And of course, we were able to remove the screw, so it's ready to be loaded again. Another case, you can see the granulation tissue, the infection around this implant, especially again on the vestibular and the distal side. We use our Lightwalker ATS laser with lots of water spray, with little energy, just enough to be able to remove the granulation tissue, which is of course softer than the bone and has a lot more percentage of water content, which here you can see the granulation tissue just flying off. The water content is the main biophysical information that we need to be able to selectively remove any kind of tissue. And here we could easily see that there is no bone removal, just disinfection of the surface of the bone with removal of the granulation tissue. Here we can see the intrabony defects, a very deep one, again all around the implant. Luckily, again, this implant was placed at the right position, I could say, so the defect is an ideal one again to augment, and it should be possible to regenerate and have a bone field in the defect. These are cases that I do with my friend Dr. Kenan Nazarov at the University of Bezmi Alem here in Istanbul. So these are all being carried out for purpose of research, and whenever they have cases like this, they call upon me and I go there once or twice a month to do these cases, and we see very nice results. Again, bone field, membrane coverage, and suturing. Of course, it's always a good idea to remove all the restoration and place a healing cap on the implant, and actually to carry out the augmentation and having a primary closure, which is the best way to go, in my opinion. The twin light procedure, I can say, is performed according to the following 5 steps. Why twin light? Because we want to use 2 wavelengths with 2 different properties. First, we use the Erbium laser in LP mode. This LP mode is the soft tissue mode, which can only remove actually the soft tissue, so it will not be removing any healthy bone. Then with the step 2, we do the bactericidal treatment and removal of the biofilm on the implant surfaces with lower energies and shorter pulse durations, which are safer for the heat. And then on step 3, we do ablate a little bit of infected bone with state-of-the-art QSP mode of the Lightwalker. Then of course, main aim here is to have some bleeding coming from the bone so that we have a better regeneration of the defect and better blood supply for the bone substitutes. Then we go on, before placing the bone substitutes, we go on with the Nd:YAG laser, which is not absorbed by the hydroxyapatite. That means it will go deep inside the bone and it will reach the peripathogens, which are usually pigmented. And this wavelength of our Nd:YAG is easily absorbed on pigments that will heat the bacteria up and give us the deep disinfection effect. Then, of course, at the end of the surgery, we have again a use of Nd:YAG with lower powers, which will be the powers of the laser will be absorbed by the organelles of the cells, especially the mitochondria, which will speed up the ATP, the adenosine triphosphate production, which again at the end will result in biomodulation and biostimulation and faster healing with less pain and less edema for the patients. So following all these 5 steps, we have a very high success rate, very low infection rate, and very nice filling up of the defects. But if you prefer to do so, it's all in the machine, very simple. Another case that we did with my colleague Zafer, here you can see the defect even before loading the implants with the gingival fiber on. You can see the defect around the implant. Then we used Wavelength laser to remove the granulation tissue and to disinfect the implant surface, and then we used the Nd:YAG of our twin light treatment concept to do the disinfection on the bony part. It's very important to know that the Nd:YAG is very well absorbed on titanium, so the use of Nd:YAG on the surface of titanium should be avoided as much as possible. So the laser should be always directed towards the bony side with no contact. Here we see the post-op 3rd year. That's the lower right implant there with new crowns and telescopic prosthetics on the upper jaw. But the patient was very happy with the treatment, with the removals, but then on he was socio-economically able to have more implants placed. So that's what we did. This is the close-up view after 3 years. And then here you can see that's the most mesial implant on the lower parts, on the right lower jaw. And here you can see that even after doing these 4 implants on the lower jaw, after 5 years, the patient said, okay, I want now more implants. So we placed 1 implant sorry, we placed one more implant on the most distal part on the lower jaw, and we did a fast and fixed, or all-on-4, actually this was all-on-6, on the upper jaw with a little bit of problem on the most distal. Restoration here you can see, but it was later on fixed, and this is after 5 years of the peri implantitis treatment. Here you can see there is no loss of the filled bone. Then coming to this case, unfortunately we are not able to save all the implants. We are not able to augment all the defects. So sometimes if the problem is too huge to solve like that, and especially like this in this case, when the implants are very close to each other, and even if we do try to disinfect and fill all those defects, you'll see later on the next slides, it will recur most probably because there is no attaching during these parts. The implants are very close to each other, and the patient is more than 80 years old, so we decided to extract the implants. This is actually the mother of a colleague who also did a Master of Science degree in Aachen University. Here you can see, after bleeding and probing again, we see probing depths up to 9 millimeters here. And when we open up, we see the view, implants almost touching each other on the apical part. Then we use again in high water volume spray the erbium laser to remove just a little bit of bone from around the implants. This tip is about 0.8 millimeters on the tip, so the amount of removal is less than a millimeter, let's say a millimeter, because the deeper you go, the wider the tip gets. So we can say just a little bit, just a millimeter of bone removal around the implant. And here you can see the implant sockets, which were maintained highly thanks to a RIMAC laser removal of the bone around the implant, and then we used our NDAC to disinfect the site. Then we augmented sites. And this is what my colleague did after 4 months of the treatment. The more implants, the better was what he was saying. Again, the patient was more than 80 years old, but I don't know if she was lucky or unlucky to be the mother of a dentist, so that she had 2, 4, 6 implants. Thank you very much for your attention, and now if you have any comments or questions, I think I can answer them. I hope it was a very good overview for peri implantitis treatment, and I really recommend this mode of treatment, which is fun and successful.
Thank you, Dr. Madden. Any questions can be typed into the question box or the chat box on the bottom right corner. While we're waiting for questions to fill in, I'd also like to let everybody know that, again, we want to thank Dr. Madden for his time, and Dr. Madden and Dr. D'Alessandro and a couple of other docs will be doing advanced perio course, if you will, to include treatment of peri implantitis, grafts, pocketing of 7 millimeters and above for us this summer, and we wanted to make everybody aware of that. The dates we're looking at are going to be the weekend of August 20th, if you want to mark that in your calendars, and will more than likely be in the New England area. So we'll confirm the Boston hotel, etc. shortly. If you'd like to be put on the waiting list for that course, please email either myself or Alexia, or give us a call. Alexia's email address is aeng@t4med.com. We've got a question for you, Dr. Madden.
Okay.
Let's see, first question is, could you provide laser settings for the for the 5 steps? I suppose the screen that you had in your presentation that showed the 4 laser screens would probably suffice to answer that, if you can leave it up for a second for the settings.
This one, of course, is giving just the pulse durations, but I can easily say that for the step 1 in LP mode, again, we can use anything from 120 to 180 millijoules with 10 hertz. This is where we check if we are removing any bone or not. 120 millijoules would be the safest, but if you want to speed up, you can go a little bit higher with the energy. Then for step 2, we use 80 millijoules, 10 hertz in MSP mode for the removal of the biofilm. And for ablation of infected bone, we use QSP mode, 180 millijoules and above. It's all safe for the bone. For deep disinfection, we use around 2 watts, 20 hertz. That will be 100 millijoules per pulse. And for biomodulation, we use the biomodulation handpiece with half a watt and 10 hertz.
Dr. Blunston would like to know what the average range of time spent per implant, per setting, and each of the 5 steps are, which, well, maybe a difficult, long-winded answer. I know that's something that we're going to spend much more than an hour of time addressing in the course, but if you can provide a little bit of guidance there, that might help as well, Dr. Madden.
Yeah, the longest would be the step 1, because we use settings that is able to remove the granulation tissue. But what we do is, of course, here we do not remove the granulation tissue layer by layer, just like doing a gingivectomy. But what we do is we go in between the bone and the granulation tissue. So we detached actually the granulation tissue. So that would take, let's say, about a maximum 5 minutes. So about 1 to 2 minutes for the disinfection of the implant surface, depending on the surface, how much implant is exposed. But let's say in average 1 minute, but up to 2 minutes. The ablation of infected bone would again take 1 to 2 minutes, because we just go over, just scan the bone and then do just small holes, which would take about a minute or 2. Disinfection of the bone with NBAC, half a minute, and biomodulation is 1 minute per implant after the surgery.
Is detoxification of the implant surface done in contact or non-contact mode? To expand upon that, I'd ask, can it be accomplished with the tip or tipless handpiece?
Well, non-contact is a better idea, because we always, to be on the safer side, we need the water spray. So with the contact mode, if we touch the implant's surface, it could be the case that we could create some heat. So even though studies show that it's safe even without water spray, I would just use the non-contact tipless handpiece so that I know that I always have the water spray on the surface of the implant. But again, in very narrow and deep defects, if it's not possible to have some angulation to direct the light towards the implant surface, of course I would use either the pips or the X-pulse tip, which are side firing. So if it's, let's say, 5, 6, 7, 8 millimeters deep inside the pocket, and sometimes it's 1 to 2 millimeters wide, then it's not possible actually to use the non-contact handpiece to reach the deeper parts. So I would use the pips or the X-pulse tips to go in and fire the laser on almost 45 degrees.
Have you been successful treating cases without removing the implant crown? Obviously, access is ideal with the crown out of the way, but have you had experience doing that?
Well, on the, let's say, lower anterior teeth, where the crown, is not bulky and it's easier to have the angulation of the tip if you're using the tip, etc. Yes, but usually I prefer to get the crown out.
Can you provide some guidance as to what your post-op regimen is with regards to analgesics, antibiotics, etc.?
Analgesics, paracetamol, as usual. Well, if the patient is systemically healthy and if there was no active infection before my intervention, I try not to use antibiotics, which is a little bit strange for even because now we know that many colleagues prescribe antibiotics even just for placing the implants. But when I'm sure that I clean thoroughly and I use my Erbimeag and NDR, then there is very little risk for infection. But to be on the safer side, again, it could be easily prescribed. But again, as I said, for the means of possibility of resistance, I would think it twice. Well, I do use chlorhexidine mouthwashes, whether I prescribe the antibiotic or not.
Another question is, can you repeat or confirm that you are using a radial firing tip at the apical portion due to access?
Yeah, if it's a difficult defect to access, I do use the pips tip, because it's when I use the straight firing tips, I know that the laser is not going towards the sides of the tip. So that would mean if I go straight, the laser will go straight. So I would be able to remove the granulation tissue maybe on the bone, but I would not be able to really clean the space in between the threads. So I need the side firing tips. That's why I use the pips.
That makes sense. Dr. Connors also asking a follow-up question with regards to interaction with the laser, and that is whether you've experienced arcing when the laser energy interacts with the implant.
That happens especially if there is not enough water spray. So we have to make sure that we increase the water just enough so that there is always mist on the surface. So, but if the implant is dry or if you're in contact, then we can have that. So we should try to avoid it. Even though, as I said in the literature, it says it's safe, water spray is always good to have with Erbium.
And certainly the Nd:YAG will arc with or without water, so please try to keep the Nd:YAG away from the implant surface if at all possible. We have a question with regards to one of our doctors that's got a case they're working on right now. Implant was placed 5 weeks ago. Case involves a 68-year-old male. MH good. Implant number 12. site-placed apical apical lesion only. Lesion is only around apical area, supporting good bone, no coronal issues with the bone. Can you flap and repair using the same protocol described?
So there is a lesion on the apical part of the implant. Is that right? Or
yeah, the word he used is dehiscence.
I see. Yeah, no problem. As long as if you're able to reach all the parts of the defect, that would mean if the defect is going around the implant, if you open up from the vestibular side only, it would not be possible actually to reach all the empty space, or it will not be possible to remove all the granulation tissue. But if you can probe and feel and touch the defect, and if you're content that you have cleaned all the granulation tissue, yes. But as on normal apicectomies, without removing the apical part of the root, we cannot clean the palatinal part of the lesion. So as long as you can reach all the volume, let's say, you can do that.
Any other questions? Dr. Madden, I know, oh, we've got one more that just flew in here.
Yeah.
Can the PIPS tip function in the same way it does as in an endo situation if we keep the fluid to a proper level?
Well, it's a little trickier to have let's say the defect filled with the liquid because with the rubber dam and the more enclosed space it's easier, but I do use PIPs, for example, for cyst cavities, which is more confined, and especially if I'm trying to make sure that there is no epithelium left, etc. I do use it for surgery. But for peri implantitis, the defect shape is very important. If it's a circumferential defect like the one that I showed on the first case, it could easily work. But when you have a dehiscence on the vestibular side, for example, it's very difficult to fill that defect with the liquid. So as long as you feel that it's full with the liquid, yes, you can do it. But then, of course, we need some research on what the energy should be, because on the endodontical canal volume, this low energies that we use is more than enough. But when you talk about a defect around the implant, of course, volume-wise, it's pretty much higher, so we need higher energies to get the same effect. But after doing all these steps, why not do it so that you, even if you have just left a little bit of the biofilm, the PIPS protocol will remove the biofilm.
Can you tell everybody what type of graft material you're using?
Mainly bovine or, well, biorite, mainly actually. But, of course, depending on what the patient wants, I could go for synthetics because not all the patients really like to use an animal or allograft. So, but normally I would prefer to use the BioGuide and BIOS.
Let's see here. What are you using for cement removal without bone involvement, setting-wise? I know
I think we could use a regular variant tip for area, or again the X-Pulse or the PIPS with 50 millijoules, 40 hertz.
Okay. LPRF augmentation with your surgeries, have you tried any of that with these cases?
Can I get that again?
LPRF.
Yes, actually, I do use LPRF regularly, and especially in the cases where I'm not sure that if I can primarily suture. If I cannot have a primary closure, then I use PRF for sure on top of the membrane. And if I am going to do that, I get extra PRF to mix it with the bone graft so that I have some growth factors, etc., going among the graft. And even if I have some opening of the wound, I know that my PRF on top of the membrane will protect my membrane from infection.
Very good. I think we've got through most of the questions, Dr. Madden. We've got a lot of interest in the topic, and again, I greatly appreciate your time. I know a lot of doctors have mimicked that sentiment, that we thank you very much for the information and you waking up at an ungodly hour in the middle of the night to do this for us. Again, I repeat, Dr. Madden will be flying over this summer to join our team here and put on one hell of a course to discuss this in a heck of a lot more length and to include a lot more surgical applications. As you've seen during just him answering some of these questions, you can use the laser in so many more ways than we're even thinking of, and it takes, in some cases, a brilliant mind like Dr. Madden's to figure all this stuff out for us. So a lot of golden nuggets will be shared and presented with us. I hope everybody can make it. Again, please email myself or Alexia, and we can save you a spot for the weekend of August 20th, and come see Dr. Madden, Dr. D'Alessandro, I believe Dr. Terry. Come see all these guys live, because it's going to be one heck of a course. Anybody has any other questions, feel free to reach out to myself or Keith. We look forward to seeing and speaking to everybody soon at some point. And Dr. Madden, again, thank you so very much for your time. We appreciate it.
My pleasure, Dimas. Thank you very much.
Good morning to you, and good night to everybody else.
Cheers.